Welcome, future nurses. Today, we're building your clinical judgment by stepping straight onto the OB floor to manage a high-stakes postpartum hemorrhage scenario together. I'm really excited to guide you through this explainer because, well, we aren't just going to memorize a list of drugs today. No way. We're going to learn exactly how to think like a nurse and make those life-saving decisions when literally every single second counts. So let's just dive right in. Picture this. You walk into your patient's room. She delivered a healthy baby 20 minutes ago, but suddenly she's soaking through her pads, her uterus feels boggy, and her blood pressure is dropping. Your immediate action, of course, is to massage the fundus, but you know medications are next. To save her, we can't just rely on rote memorization. Instead, we're going to use a simple four-step framework for every single medication we cover today. What is the patient's problem? Which medication should we anticipate? What is the biggest danger? And finally, what should you monitor or do? In a postpartum hemorrhage, or PPH, the situation evolves in an instant, and your clinical judgment is the only barrier between a close call and a tragedy. Here's the game plan for our hemorrhage cart today. We'll cover 1. The boggy uterus emergency. 2. The hypertension trap. 3. The asthma trap. 4. The multi-purpose option. 5. The clot stabilizer. And 6. A rapid-fire review. Starting off with Section 1, the boggy uterus emergency. Applying our framework, let's look at Step 1. What exactly is the patient's problem? The problem here is uterine atony, which basically means the uterus has lost its muscle tone and just isn't clamping down to stop the bleeding. Step 2, which medication should you anticipate? You should immediately anticipate oxytocin, which is commonly known by its brand name Pitocin. It's a synthetic peptide hormone, and it is our standard first-line uterotonic. Okay, Step 3. What is the biggest danger here? Well, the danger, particularly with prolonged high IV doses, is water intoxication. You'd also worry about tachycystole if it were given before birth, but right now, we're safely in the postpartum phase. And finally, Step 4, what should you monitor or do? Your nursing priority is to constantly assess that fundal tone, check the lochia or bleeding, monitor vital signs, and quantify the blood loss. For patient teaching, just reassure her that the intense cramping she's feeling, that actually means the medication is working to stop the bleeding. Moving right along to Section 2, the hypertension trap. Let's evolve the scenario. You've massaged the fundus, the oxytocin is running, but the heavy bleeding is still going. As you reach for the next uterotonic on your cart, you notice her blood pressure has spiked dangerously high, up to 160/110. She also has a history of preeclampsia. So, which medication is now strictly off limits? This right here is our first major NCLEX and clinical practice trap. If you give the wrong medication at this exact moment, you could cause a massive stroke. Lock this clinical pearl into your brain forever. Never administer Methylergonovine to a patient with hypertension or preeclampsia. This drug is an ergot alkaloid, which means it causes incredibly strong uterine contractions. Now that's fantastic for stopping bleeding, but it also causes severe vasoconstriction throughout the body. In a patient who already has high blood pressure, this can instantly provoke severe hypertension, strokes, or even seizures. So let's run this through our 4 steps. Step 1, the problem is postpartum hemorrhage and a normotensive patient, meaning absolutely no high blood pressure. Step 2, you anticipate Methylergonovine. You might hear it called by its brand name, Methergine, and it's usually given IM. Step 3, the biggest danger is severe hypertension, stroke, or seizures. And Step 4, your absolute priority nursing action is that you must always check the blood pressure right before administration while continuing to monitor bleeding and uterine tone. When teaching the patient, advise her to immediately report any severe headaches, because that can indicate a dangerous spike in her blood pressure. Let's quickly compare these first two so you can see the clinical reasoning. We go with oxytocin first because it's just universally safer. It's our standard frontline defense. Methylergonovine, on the other hand, is a powerful second-line backup, but because of those severe cardiovascular effects, it absolutely requires strict blood pressure screening. You're going to use oxytocin almost universally, but you must actively pause and think before pulling Methylergonovine. All right, Section 3, the asthma trap. Let's reset our scenario for a second. Let's say your patient's blood pressure is totally normal, so hypertension is off the table. But you spot an active, severe asthma diagnosis right there on her chart. Which PPH med just became a life-threatening choice? Just like high blood pressure eliminates one drug, asthma completely eliminates another. This triggers another major clinical judgment checkpoint for you. The rule here is simple, and it is non-negotiable. Never administer Carboprost tromethamine to a patient with asthma. Carboprost tromethamine is a potent prostaglandin used for refractory atony when the uterus just won't firm up. But a major adverse effect is severe bronchospasm. For a severe asthmatic, giving this medication could immediately and completely compromise their airway. Let's look at the framework again. Step 1. The problem is refractory uterine atony, where oxytocin just isn't enough. Step 2. You anticipate carboprost tromethamine, commonly known as Hemabate, given IM or sometimes straight into the uterine muscle. Step 3. The biggest danger is bronchospasm, along with some pretty severe diarrhea and fever. Step 4. Your critical nursing action is to meticulously assess the patient's respiratory history and current respiratory status before you give it, all while watching that bleeding response. For patient teaching, just give her a heads up that this medication often causes uncomfortable GI side effects, like really severe diarrhea, so she knows exactly what to expect. This brilliantly illustrates the classic head-to-head NCLEX trap you're going to face on exams and out on the floor. It's essentially a battle of the contraindications. You have two incredibly strong backup uterotonics. You must actively rule out hypertension before giving Methylergonovine, and you must rule out asthma before giving Carboprost tromethamine. Your clinical judgment is the safety check that prevents these life-threatening errors. Moving on to Section 4, the multi-purpose option. So, what if you need an option fast, but the patient's IV access just blew or is otherwise compromised, and you need a flexible alternative right now? Step 1. The problem is you need a rapid alternative uterotonic. Step 2. Anticipate Misoprostol, widely known as Cytotec, which is another prostaglandin. Step 3. The biggest danger includes fever, chills, and severe diarrhea. Step 4. As the nurse, you need to monitor her temperature closely. For patient teaching, reassure her that a sudden spike in temperature or shivering is actually a very common side effect of this specific drug and is usually temporary. What makes Misoprostol so fascinating and honestly incredibly useful is its absolute versatility. When we compare it to oxytocin, which strictly relies on an IV infusion or an IM injection, Misoprostol gives you options. Depending on the immediate clinical situation and the provider's order, Misoprostol can be administered orally, buccally, right in the cheek, or, very commonly in a massive hemorrhage emergency, rectally for rapid absorption. Section 5. The Clot Stabilizer. Okay, we've squeezed the uterus with our uterotonics, but what if the bleeding just won't stop and we need one more critical intervention? The massive hemorrhage protocol will often call for this. Step 1, the problem is ongoing hemorrhage, despite our previous efforts. Step 2, anticipate tranexamic acid, which belongs to a class of drugs called antifibrinolytics. Step 3, the biggest danger is the risk for thromboembolism, blood clots traveling in the body, as well as hypotension if it's infused too fast. Step 4, administer the IV infusion promptly per your facility's protocol. For patient teaching, educate her on the signs of a blood clot, like a sudden sharp half pain or shortness of breath, and tell her to report those immediately. Understanding the mechanism of action here is absolutely vital for your clinical judgment. Our uterotonics, like oxytocin, Methylergonovine, Carboprost tromethamine, and Misoprostol, they all stop bleeding by physically clamping down that uterine smooth muscle. Tranexamic acid, it works entirely differently. It operates in the bloodstream to stabilize forming clots and prevent them from breaking down. It does not contract the uterus at all. They work together as a team from two completely different angles. And finally, Section 6. Let's do a rapid-fire review. You've successfully navigated a highly stressful, constantly evolving patient scenario. You ruled out hypertension, you checked for asthma, and you managed the bleeding. Now, let's lock in that clinical judgment. I highly recommend taking a quick screenshot of this breakdown. Let's run through it together. Oxytocin, used first line for atony. Route is IV or IM. Major danger is water intoxication. Your nursing priority is assessing that fundus and blood loss. Methylergonovine, used for strong contraction. Route is IM or oral. Danger is severe hypertension. The absolute contraindication is high BP or preeclampsia. Priority, checking BP first. Carboprost tromethamine, used for refractory atony. Route is IM. Danger is bronchospasm. The strict contraindication is asthma. Priority is assessing respiratory status. Misoprostol, used as a rapid alternative. Routes are highly flexible, oral, buccal, rectal. Side effects are fever, chills, diarrhea. Priority is monitoring temperature and tone. Tranexamic acid, used for ongoing hemorrhage. Route is IV. Danger is thromboembolism. Priority is giving it promptly for protocol and watching for those clots. Let's leave off with this final provocative thought. If your postpartum patient is hemorrhaging, heavily hypertensive, and severely asthmatic, which life-saving pathway will you choose? Well, by knowing that methylorganovine and carboprost tromethamine are strictly off the table, you automatically know to advocate for oxytocin, misoprostol, and tranexamic acid. The next time you step onto the OB unit, you won't just know the names of these medications. You will know exactly how to think like a nurse to save a life. Keep practicing these scenarios. Trust your judgment, and I'll see you in the next explainer.